detail, but we provide technical expertise to countries. Increasingly, we find they really have this technical rigor. 15 years, 18 years ago when I started, there was a need for a lot of lab training, epi training, clinical training. We find more and more capacity in the LMICs in that regard. And so a lot of the work that we do is around operational excellence, doing project management training, leadership training, focusing on governance and policy, and really driving political engagement to get policy action for domestic budgets and legal infrastructure. So we started back in 2018, 2019, and the map looks pretty much like this. When we started, the World Health Organization had just undergone a huge reform after West Africa Ebola. I had also spent the best part of 2 years in West Africa with the Red Cross and came out of West Africa Ebola straight into the yellow fever outbreak in Angola and then straight into a large cholera outbreak, and really was going back to West Africa over and over again and just thinking that there had to be a better way we could focus on preparedness. So I started to engage at the Red Cross and WHO and others in this idea of how do we strengthen those health systems. And the WHO created a tool called the Joint External Evaluation. It's a capacity checklist across 19 technical areas. And by 2019, 100 countries, those on the map, had undertaken the Joint External Evaluation, and it had identified more than 7,000 gaps in capacity. But really importantly, when we looked at those plans, it had taken 420 days to go from assessment just to an approved plan. By the time we started to work with countries, they were what we call NAPS fatigued. No one wanted to hear the word NAPS anymore. No one wanted to talk about plans. It had taken a huge amount of effort and almost 2 years to just agree on a plan. And so when we went to countries, we found that they had these really extensive plans, often with 500 to 700 activities, often $100 million costed plan. But we also found that they had money available, but it was really difficult money. It was in the World Bank or it was in Global Fund vertical programs. And essentially countries had plans, they had money, but the money and the plans didn't match and they weren't able to use or move that money. And the other thing that we found was the same people that were responsible for response when I was working in response, going to countries, were the same people responsible for preparedness. And one of the big takeaways from me and my time in the field was I was responsible for response, never prepared, because I was either responding or I was asleep, getting ready for the next emergency. And so all of these lessons really impacted the way that we started to approach this work. So initially, this idea was that if a country did an assessment and they prioritized that plan, that they could cost it, then they could finance it, and countries would step up from red to yellow to green. They would go from being underprepared to improving their systems and then eventually be fully prepared. And it would be this fairly linear process. And what we realized fairly quickly is that there's nothing linear about it. Actually, countries go up and down from yellow to red and back to green, depending on the outbreaks, depending on the leadership, depending on the political situation. But also, as they get better at assessing themselves, they often are more critical. We just saw the Nigeria CDC reassess their scores under the Joint External Evaluation and mark themselves down across the board, even though they'd improved significantly, because they started to think about subnational capacity, not just national capacity. So this idea that you just have to make a plan and find the money and you can improve really turned out not to be true. And so as a team, we really started to focus on how we could support the provision of dedicated teams that really focused on preparedness, that woke up every day thinking about how to implement these very complex plans. I'd worked in multiple complex emergencies, security, famine in Somalia, conflict, earthquakes, but national action plans are one of the most complex plans I've seen across 19 technical areas, often against 8 to 9 ministries, all not necessarily prioritizing the outcome of these plans. And so at Resolve, we provide funding and support to teams of 5 to 7 people that are a mixed disciplinary. We have a health person, a One Health, a lawyer, a communications expert, often a monitoring and evaluation expert, that really focus on supporting countries to implement their national action plan and to monitor and be accountable for progress. So as I said, we use the top approach to do that. And what that looks like for us at the Prevent Epidemics team is a really important program that we call PMAP, Program Management for Epidemic Preparedness, where we accompany teams of people from countries, 4 to 6 people, and we provide 12 months of coaching and mentoring, as well as in-person training for project management, stakeholder engagement, negotiation, diplomacy, as well as project management and design skills. And we really think that that's, one of the secret sources. We've seen huge acceleration in teams that are able to go back and to manage these complex programs and to really implement and utilize the money available. The other big piece that we have, which is a bit different to other partners, is that we have a really big legal team. So we have more lawyers than epidemiologists at the moment, and the epidemiologists remind me regularly, but we have 12 lawyers on staff. And it's really because after the pandemic, the political process is very open to change. So we had struggled to help countries update their public health law, many of which were written in the 50s and 60s as the colonial powers transitioned away. Many of the laws they left behind are fairly antiquated, but the demand for legal support right now is extremely high. And actually just today, we passed 5 bills in Nigeria, ranging on public health, One Health, health access, and budget financing. So the legal team's been very busy making the most of the political engagement and interest in COVID, post-COVID, to really help strengthen public health law. So we have that big legal team, and they're accompanied by a domestic financing team. As we pass those new laws, we mobilize grassroots organizations to really put pressure on governments to create domestic budget lines. Often not large, but it's important that there's a line in the budget for health security, for preparedness, that governments can start to add money to as their GDP increases. So we take this very, what we call systems thinking approach to supporting countries across the top areas to really support them build stronger systems. So we've been doing this for a while now, and we really came away with 5 key lessons for implementation that we think will help countries really prepare and respond to epidemics and make them more prepared for preparedness. And the first one is to really activate political leadership and multi-sectorial coordination. And there's been a lot of progress and discussion for a long time about the One Health approach. Many of the countries, especially in Africa, have a One Health platform, but it hasn't been active. It's been a technical working group, it's been information sharing. And what we found is we really need political engagement above the Ministry of Health. The Ministry of Health and the National Public Health Institutes have to play a key role, but there's no way that the Ministry of Health can call out the head of defense or the head of environment or for not completing their tasks, for not completing their implementation in the NAPs. And so where we found this is extremely important is having the health security teams report up into the Office of the Prime Minister or the Cabinet, where the different ministers are all held to account for their contributions to health security. And we've been able to achieve that in 4 countries now, where the teams that are implementing actually have a dotted line up into the Office of the Prime Minister or Cabinet and report every month on their health security activities. The second lesson is that establishment of that multidisciplinary team that are dedicated. Preparedness has to be someone's job. It can't be something that someone does on top of already working 110%. Having those multidisciplinary teams really driving preparedness and connecting across the ministries has been critical to making progress. But it's been important to implement very simple project management tools. Sometimes I'm surprised at how simple they can be, but one of the key lessons for us is a simple tracking system that helps countries understand and visualize their progress on implementing their tasks from the National Action Plan and making that available to everyone in real time. Number 4, we'll spend some more time on. Mike referred to it as the 717, but it was one of these key lessons for us was using rapid quality improvement to drive systems change by really focusing on timeliness. How quickly are you able to find an outbreak? How quickly are you able to respond? And how do you make sure that your systems are fit for purpose? And then the 5th one is really important, especially as I'm here at the World Health Assembly, is streamlining partnerships and aligning donors. What we found is that there's lots of different partners on the ground, all asking countries to implement in different ways, providing money for one thing but not another, and lacking real coordination. And so we work with countries to really try to help donors and partners work from one plan to really make sure that they're making progress on what the country has prioritized rather than what donors or partners are bringing to the table. So what that means for us, what we do is we have 5 flagship projects. Internally, we have kind of brands for them. The first one is Step Up. This is a project that helps countries move the technical needle on those 19 technical areas from the JEE, really focused on using a WHO guidance tool called the benchmarks. It's like a recipe book for health security, and we fund and support countries to implement those activities to make sure that they move their JEE scores from red to yellow and yellow to green. The second workflow for us is this Accelerate Detection and Response, known as the 717 project. And we're just starting tomorrow at 7:30. We will launch a new platform called the 717 Alliance. It's a new $5 million initiative to help countries take on the approach of rapid quality improvement using timeliness metrics. We also have just launched a large program called Epidemic Ready Primary Healthcare. Initially, this work was really around protecting healthcare workers and essential services during COVID, and we're now transitioning that to really focus on primary healthcare to make sure that there's a strong interface between communities and the health system, that healthcare workers on those front lines are protected. They know and have access to PPE and other behavioral protections like washing hands. But really importantly, that they're trained on surveillance and case management, that they understand the case definitions, that they're able to have a high level of clinical suspicion, and they're able to identify potential epidemic cases, report those, but more importantly, be able to protect themselves when they see those cases, protect their health facility, and provide initial case management. So we'll be implementing that in 2,500 health facilities across 4 countries, really trying to learn how we can support nurses and frontline healthcare workers to be our eyes and ears for early detection and be safe while they're doing that. The 4th area is that project I mentioned, the project management. It's one of our high demand projects. This type of support is really requested by multiple countries in terms of helping their senior leadership really get better at implementing projects and really leading implementation. And then the 5th area is around epidemic intelligence, and we're starting a large new project with the Gates Foundation and several others on how we bring more data more effectively into the emergency operations centers to improve decision making in real time, looking at everything from the data entry all the way up through to the data analysis. So we have those 5 major flagship projects that work across the team, and we focus that work in 5 countries. We have those embedded teams, and we support another 10 countries with wider technical support. But what I thought I'd do today, given that it's top of mind and that we're launching tomorrow, is spend a little bit more time really focusing on why we called for a new global goal known as 717. So as I explained at the beginning, one of the biggest challenges that we saw really was this very heavy planning process, 500 to 700 activities in the National Action Plan, countries needing tens of millions of dollars to be able to implement that plan. and those plans being very difficult to implement. And one of the challenges that we worked with countries on is, how do you prioritize out of those 500 things? How do you choose what to work on first? And there was the normal kind of processes of prioritizing, high impact and low cost, coming first, quick wins, things that you had money for. But the more we thought about systems change, the more we looked at other system strengthening activities, there's definitely an order of operation. You have to break path dependency. You have to find the areas of your system that are going to have the biggest impact and make changes there first. And we saw really good results from countries that were implementing after action reviews. So we started to support a number of countries to really come together after large events and understand what worked and what didn't. Madagascar was one of the first we really supported after a bubonic plague outbreak. And we found that they were really able to identify, 10 key things that went wrong during their response. We were able to provide as little as $300,000 at that last day of that meeting, and the country was able to go away fully motivated about making that change with some money to implement that. We're able to implement that project within 8 weeks. And in the next season, where we were expecting plague, which was only 3 months later, we didn't get any cases. Now, it's seasonal, you can't, there's no causation, but essentially we were able to really make rapid change by using the momentum on that back of that after action review. But what we saw with the after action reviews is that you only do them when you do a really big event, which means you did something wrong. You missed the outbreak. And the lessons were really focused on the heavy response. There was a lot of emphasis on response teams and clinical management. And at the same time, we'd been looking at an advocacy document that I'm happy to share in the chat called Epidemics That Didn't Happen. And this advocacy document really came around because when public health does a good job, nothing happens. And that's when we lose money, we lose political engagement, because they don't have a reminder of the services public health provides. So we have this advocacy plan called Epidemics That Didn't Happen, and we collect case studies of epidemics that could have been disastrous, but that public health officials found and controlled quickly. And one of the common elements when we had those case studies was that they found those outbreaks early and they responded quickly. And so we started to look at how we could really look at those first few days of an outbreak and understand what was working and what wasn't. And we did some meta-analysis from existing documents. We used the timeliness metrics, which are already a well-accepted surveillance M&E tool. And we came up with this idea of packaging it, very similar to where you will have heard 90-90-90 for HIV. It's not a coincidence that 717 sounds similar. The idea is to really provide a common framework for multiple partners to focus on the core systems of early detection and response. And so the project calls for every country in the world to find outbreak in 7 days, respond in 1 day, and start effective response in 7 days. Countries collect this data inside their EOC for every public health event, not just the pandemic potential ones, but every event that comes through the EOC, to understand where and how their systems are performing. And they run bottleneck analysis against that, often in real time, to understand why or how their detection and response systems are working. So this is an example from the Ebola virus outbreak in Uganda towards the end of last year. Uganda's been one of our champions in using 717, and it's really changed their whole approach. Dr. Mukumbi, the lead there, said to me a few weeks ago, he really thought that they'd improved and had one of the best EOCs on the continent. And to be honest, it was known like that. But 717's shown them the blind spots. He talks about where I'm getting punched in the eye by epidemics. And so you'll see here, just on one slide, we're able to capture the performance of the system in being able to detect outbreaks. So Uganda found the virus 46 days after emergence. They were able to notify quickly in 1 day and took 9 days to respond. You'll see in those gray boxes, they'd already identified the bottlenecks. They did this in real time. They did it for the first time on day 7 of the outbreak. realized that they'd missed some more cases, did some more contact tracing, came up with that 46 days and revised this slide, I think on day 14 or 15. So they were able to address these bottlenecks in real time. They also had enablers, things that had helped them be able to respond. And they'd already created immediate actions that they needed to take right now to improve the system, as well as things that they wanted to build into their long-term planning. And in this case, it was including private health facilities in their surveillance and response training. One of the other pieces that this is really brought forward to us is the challenges that we have in surveillance systems. So that 717 piece is so important, and the more we look at the surveillance systems, the more we understand that there's actually a huge amount of data in most countries, but we're not able to access it, move it, or analyze it. And starting a new project, WHO released a new document yesterday called Collaborative Surveillance as part of their HEPA framework. And under that new approach, we're working in 4 countries to see how do we build a future surveillance state. So at the moment, a lot of the surveillance systems, especially in LMICs, look a bit like an urban slum. Each partner, each department, each donor has built the surveillance system that they need for their purpose, often side by side without any investments in common infrastructure, no water or sanitation, no green space. Essentially, these surveillance systems are common in the fact that they're ad hoc design, they're missing shared services, there's no clear policies on how improvements will be made, and they're extremely difficult to grow or to scale. Then we looked at other surveillance systems that we thought were a bit more robust, right? In the US, we looked at a number of jurisdictions and their surveillance systems, including the US CDC, and the more high-profile surveillance systems in HIV, malaria, and TB. And actually, they can be characterized as these big gated suburbs that sometimes we see, especially in the US, where they look, the houses are big, they look well-designed, they look laid out, but they're often very far from city infrastructure. They're often connected by large highways. They get choked up. They're not easy to move between. They have very strict policies and rules, which cause friction and division. They're very difficult to grow and connect. And where we're trying to get to, where we think surveillance needs to move to, is more like good quality urban planning that perhaps you see in Europe, where the focus is really on the user experience, the positive experience of interacting with the system, that it's focused on function, that there's a common goal where everyone invests in shared services, clear rules in terms of how you engage. Potentially, if you're building a new building, you have to add bikes and showers and car parks. This idea that if you're building something in the urban plan, that you have to contribute to the overall experience, not just for your purposes, but for everyone's purposes. So this is the new program that we're working on. I actually just jumped off a call with my team, thinking through how we're going to help countries get from this ad hoc urban slum design to a beautiful European style urban plan where we have plenty of green space and bike riding and mixed use cases, for example. And so this is the new challenge that we're going to take on top of the new 717 and primary healthcare projects. So maybe I'll finish there. I wanted to leave plenty of time for kind of questions or feedback in terms of the things that we're working on.
Amanda, this is so interesting, and thank you so much for sharing what Resolve is doing. And I think you've alluded to yourself, like I think the work that you're doing is having traction. Countries are buying into it, so I think that speaks to the success and the impact that you're having. Appreciate that it's late in the evening for you, and you have a very early morning meeting. So double thanks for being willing to share with the UCSF team what you're up to, with much appreciation from us all.
Yeah, and thank you so much for the feedback. I appreciate it.